So the night before surgery, you'll always get a phone call. The phone call comes from the anesthesiologist. They'll talk about health issues and talk to you about the plan for anesthesia the next day. Usually we have you show up the next day in the preoperative area about 2 hours before your surgery is scheduled. Dr. Ellman and I both will see you in the preoperative area, discuss the surgery again, answer any questions that you might have. The anesthesiologist will also see you on that day. Our typical plan for anesthesia for this procedure is 3 things. Number 1 is a spinal anesthetic that makes you numb from the waist down and lasts and lingers on for several hours even after the surgery is done, just to help with pain control. The second is called an ESP block, and it's a medication that we put in not into the spine but just next to the spine in the back that helps to reduce pain in the nerves that are coming out of the back and the lower portion. And that block can last for 24 hours or even longer sometimes, so it helps with pain after the surgery once everything's done. The other thing is we do sedation, so during the surgery you won't be awake or hearing anything, or it's going to be, you'll be completely asleep even though it's a spinal. We do sedate people heavily so that they're not aware of the surgery that's happening.
From a surgical standpoint, the way we break it up really is into 2 halves. The first half is the arthroscopic portion, or my portion. The second half is Dr. Hugate's portion, or the osteotomy portion. First portion, I like to tell patients this is the easy part. Okay, I go in with a scope, 3 poke holes. We go in and we look around. Anything that's going on in that hip that is not normal, we can fix. If your labrum is torn, I'll fix it. If you have impingement going on in there, meaning you have an abnormal shape of the femoral head and you're bumping up against the labrum, we can shave that down and resculpt the ball as well. We do that in most cases in patients with impingement. The capsule is this kind of fibrous balloon around the joint. We can tighten that up, do what we call a capsule plication. In patients with severe instability, they have very loose capsules. We see a lot of patients with what we call Ehlers-Danlos syndrome, where ligaments are lax and the quality of the capsule is not great. In those cases, we'll tighten up the capsule and do a plication to give them a more stable hip from a soft tissue standpoint. If I get into the joint and the labrum is irreparable, okay, this is a rare situation where I get in and the labrum is kind of ossified, okay. This goes back to, it's kind of weird, but it's a gummy worm analogy, okay. The labrum is a ring of cartilage that lives around the socket. It acts like a gummy worm, a gasket seal. It should be this nice fresh gummy worm that comes out of the package, right? It's a pillowy substance. If we get in there and your labrum is like a gummy worm that's been sitting on the kitchen table for a month, right? And now it's hardened or it's ossified, then you can be bumping into bone, right? And you can have a bone-on-bone type feel in that hip. And we see this, in severe dysplastic patients as well. So if that's the case, I'm not going to repair a hardened, ossified labrum. In that case, we do what we call labral reconstruction. We can take out the disease-damaged portion of the labrum and we put in fresh, reconstructed allograft tissue, cadaver tissue, to make a new labrum for you. That to me is a game time decision of whether or not I do that. But we have everything on hand and on deck. So if that's the case in your hip, I'm gonna do whatever's best for your hip. So we'll reconstruct, we'll repair, we'll do whatever we can to restore stability of your hip.
And then while you're still under anesthesia and still sedated, then my part of the procedure will start. The purpose of my part of the procedure is to move the bones into a better position. And so we'll make a 4-inch incision roughly, move the cup over into a better position, and then secure it with the screws for the PAO part of the procedure. Once the surgery is done, you'll be rolled into the recovery room. You'll be in the recovery room for about an hour and a half to 2 hours, and then head up to the floor. Both Dr. Ellman and myself, after our portions of the procedure, will call family members or friends or whomever you designate us to call and let them know how things went during the procedure, and let them know that you're doing well afterwards and where to meet up with you.